Hello, William. Thank you for being here with us, having coffee and discussing device-detected atrial fibrillation or subclinical atrial fibrillation. So, what is device-detected atrial fibrillation? How can you define it?
Absolutely. And I think to really go for the history of this condition, you need to go back to the 2000s around or so when pacemakers were going in with atrial leads and they were picking up atrial activity that was there with high rates. And eventually this got called atrial high rate episodes. The reason that it had that loose, non-descriptive term that didn't include atrial fibrillation is because sometimes it was noise, sometimes it was other things. As time went on, our ability to pick these things up got better, and our knowledge evolved that these things that we were seeing, as long as a physician had overread them and confirmed it really is rapid atrial activity and not noise or something else, to see that this is a condition that's on that spectrum of atrial fibrillation that includes paroxysmal atrial fibrillation, persistent, and permanent AFib. It's over on the other end of the spectrum, and that's why we're calling it device-detected atrial fibrillation.
Okay, but is it correlated with worse prognosis, or stroke or ischemic events, or just a bystander and not causative of worse prognosis?
Absolutely, and I think that that's the fundamental question, Andrea. And in 2012, I think the ASSERT study definitively answered that question. So what ASSERT did is it took people who were getting a new dual chamber pacemaker, it looked for atrial fibrillation, subclinical atrial fibrillation picked up by the pacemaker in the first few months, and then it basically followed them for a few years and said, are the people with subclinical atrial fibrillation having higher risks of stroke? And indeed they were. It was about 2.5 times the risk of stroke in terms of relative numbers for people who didn't have atrial fibrillation detected at all. But it brought about an interesting conundrum, because if you took patients who had full-blown clinical atrial fibrillation in any given CHA2DS2-VASc score and compared them to patients who had subclinical atrial fibrillation, the risk of stroke in the patients with subclinical atrial fibrillation was lower than the full form of atrial fibrillation. And that's why we launched the Artesia trial to ultimately try to figure out if oral anticoagulation would be effective in that population.
I believe exactly this is the real question. In medicine, we accept a lot of treatment without a little or no evidence. But in case of device-detected atrial fibrillation, we have 2 big trials, very well-conducted trials, but we still really don't know what to do, or at least in our practice, we have some doubts still.
Yeah.
So what are you gonna do with these patients?
Absolutely, and I think it's worth taking a look at the results of those trials, right? So the NOAA trial published at the time of ESC 2023 in Amsterdam. NOAA was important because it compared edoxaban to either aspirin or placebo. 54% of the patients in the control arm actually ended up on aspirin. And they had a primary outcome that included cardiovascular mortality, stroke, and systemic embolism. And they found for that top line primary outcome that there was no reduction with edoxaban. And they also found, as expected, a higher rate of bleeding with edoxaban. And this caused, I think, some confusion for a couple of months, and maybe the prevailing view that oral anticoagulation was not effective. At the AHA in Philadelphia in 2023, we presented the Artesia trial. Artesia compared aspirin to apixaban. The reason we used aspirin in everybody in the control arm is approximately 2/3 of patients in this population are on aspirin anyways. And our primary outcome was different from the NOAA primary outcome. We had stroke and systemic embolism. We didn't include cardiovascular mortality in that composite. And we showed that apixaban, as compared to aspirin, actually reduced the risk of stroke overall by about 1/3. And of course, it also increased the risk of major bleeding. Concomitant with the Artesia publication, in Circulation we published a trial-level meta-analysis where we standardized all the outcome definitions, and we found that when you pooled the 2 trials together, that the risk of stroke reduction remains statistically significant at around a third with oral anticoagulation as compared to aspirin or placebo. And of course, that was offset by a risk in bleeding.
That's a very interesting point, and I want to do you another question, if it's possible. How can you deal with the competitive risk of stroke? How you can bring in the equation and consider that these are very old patients with large arterial vessel disease and so other risk of thromboembolic events?
Yeah, I think that's a great question. So I think it's important to look at the primary outcome of Artesia was all-cause stroke. So that meant ischemic stroke, whether it was embolic or non-embolic, right? Anything across the TOAST criteria, lacunes, and that also includes hemorrhagic stroke. And of course, systemic embolism, because systemic embolism is essentially the same pathophysiology as embolic stroke. Okay. It's just the clot didn't take a left turn at some point. It just kept going right through the aorta. So for Artesia, we did use all-cause stroke as the primary outcome, and that's when we found that there was a reduction. You're quite right that there are competing mechanisms of stroke, and we see a lot of that in secondary stroke prevention populations. We've seen overall that among patients who have atrial fibrillation, about 1 in 3 strokes are due to a non-embolic mechanism. The corollary of that is in the general population that of all comers with stroke, only about 20% are due and attributable to atrial fibrillation. The good part is that these are all responsive to oral anticoagulation and antithrombotics, but certainly there's a lot of other competing pathways and places where we need to have ongoing refinement of our stroke therapies.
Perfect. Dealing back with the device-selective atrial fibrillation, the burden of subclinical AF or duration of the longest episodes, does it matter? Or
so I think that's a super question. Burden, usually defined as the percent time in AF per monitoring period. Or the other way burden is sometimes expressed is what they're now calling LEAF, longest episode of atrial fibrillation. Both of these things have been well correlated in clinical atrial fibrillation with a risk of stroke. So there is one, I think, line in the sand in subclinical atrial fibrillation, and that's the 24-hour mark. Around 2014 or 2016, there was a publication in the European Heart Journal that took the ASSERT trial and divided patients according to their longest episode over follow-up. And it used what's called a time-varying covariate analysis. So that meant that patients could actually jump categories and around. And it showed that if your longest episode of subclinical atrial fibrillation was more than 24 hours, your risk of stroke jumped up to 3%. And that's why actually, and that's 3% annually. And that's why in the Artesia trial, when patients actually had either AF detected clinically or atrial fibrillation on the device lasting more than 24 hours, they were actually advised to effectively come out of the trial, switch to open label oral anticoagulation, and be followed. Between 6 minutes and 24 hours, we actually carved that up and dissected that in a publication that was recently published in Circulation. And we found that both the absolute risk of stroke and the relative risk of stroke, or said another way, the treatment effect of apixaban, was actually quite consistent between 6 minutes and 24 hours. So it doesn't seem like there's another inflection point in there. And we don't recommend right now that that's something that we use in clinical decision making.
Okay, thank you. You were very, very clear, and we believe that we have now a better idea on what to do with our patients and with device-selective atrial fibrillation. Thank you, William.
Thank you. Thanks for having coffee with me.
Yeah, thank you.